right. Well, hi, everybody. I'm Elizabeth. Thank you so much for the privilege to be here with you today. I've learned so much from all of the questions, from the different speakers, and it's always such an exciting time to really spend time in the company with other infection preventionists and other stewards, because I think that through these opportunities, that's how we all learn. So I started my stewardship journey through a number of different channels. It was kind of a little squiggly, as you can kind of see on the screen here. I actually was IP working at a very small community hospital. I actually got that job because of an infection preventionist. I was a NICU nurse, and I just always liked microbiology. And I said, you know, I'd love to spend some time with you. And she's like, that's great. And Donna down the street is hiring. Maybe you can become an infection preventionist, come back to Children's at some point. And I did just that. When I was working with Donna, she was a fabulous mentor. And we, during the course of my time with her in the small community hospital, we were experiencing a couple C. diff outbreaks. One that was so significant around 2002, 2003. It was really before the CDC had the criteria for calling a hospital-acquired condition related to C. diff. So we created our own case definitions. We were diluting bleach. I was receiving lots of angry calls around the diluted bleach because we were bleaching everything in the work environment at that time. Lots of calls to the CDC back and forth to try and figure out how to stop this outbreak. And doing the same work that you all do each day, you know, I started with a literature review because I thought, you know, there's got to be something else that we're not doing to address this outbreak. And that's when you started to see some of the different papers around fluoroquinolones. And potentially, you know, if we stop them, people don't always initiate them. You know, there's a relationship between that and C. diff. And so there was really an opportunity for us to look at that within our own facility. And I remember approaching my medical director at the time because I said, you know, we're doing all this other stuff. Is it possible we could look into this? He's like, Elizabeth, and he's a wonderful medical director. He's like, we just don't have the bandwidth in which to do that. You know, fortunately, the outbreak abated. I moved on to other infection prevention roles where teams were forming. And in fact, when Jason Newland started the stewardship program at Children's Mercy many years ago, as a nurse and an infection preventionist, I was working there at the time, and I didn't really see a place for myself in antibiotic stewardship at that time. And then I had a brief stop in clinical safety where I learned a lot about organizational context and, you know, how do we work between different groups of people in the work environments. And it was until later at an FAPIC conference where in 2015 where I had the opportunity to meet with Mary Lou Manning, who's an infection preventionist. She was our FAPIC president in 2015, in fact, as a nurse by background. And I said, you know, I'd like to study something that would be important to the infection prevention community. And I said, where do you think I should start with this? And she's like, Elizabeth, I think a good place would be antibiotics and nurse engagement in that. And really here I am all those years later. And I've served in a number of roles in my 25 years as a nurse, but the majority of those have all really been because a nurse, an infection preventionist, has kind of shaped that pathway. And so the message really to leave that with today is you never know what types of conversations that you may have that will have a very deep impact with the people that you work with each day. So I think when we think about the topic of nurse engagement and antibiotic stewardship, how do we make space for those perspectives? I think it all begins with a conversation that you may have with people. So just to kind of orient us to what I'll be covering over the next 45 minutes or so is really to review the current science of nurse integration and antibiotic stewardship. So there's been some papers that have come out in the past several years, so I'd like to discuss a few of those. You know, I'm from Missouri, so we're a very pragmatic people. You got to show us. And so I'd like to also cover some different strategies of how to begin your work as far as building collaboration within these stewardship efforts. And then also to really end with talking about the synergistic relationship between infection prevention and antibiotic stewardship. And I'll touch a little bit about diagnostic stewardship because that's really gaining a lot of traction within the literature and within our communities. So again, the orienting message here is that nurses can and should make significant contributions to antibiotic safety, and they do this work every day. And so sometimes, you know, that recognition isn't always there, but as infection preventionists, as stewards, I think we can help create those conversations so they can help see that connection because they do, in fact, serve in that capacity. So you may be asking, why nurses? We're not prescribers. We're not the individuals that are really making these complex decisions around drug safety like pharmacists do. Well, there's a lot of us. We practice in every setting. We practice in all different types of setting where oftentimes, as you've heard from other presenters, where infectious disease experts like yourselves are oftentimes lacking. And so, again, we recognize, too, that that model cannot always be sustainable, especially when I think about, where I practice, and we have a lot of critical access hospitals that funnel into the greater Kansas City area. And so how do we create better systems? And I think part of that includes engaging one of the largest healthcare disciplines. So what you see over here on the, I always get my directions, the left is really an image from the American Nursing Association and the CDC, where really nurses are natural partners in the work too. So again, regardless of care setting, although this focus was really around acute care, is that we really do interface with so many different disciplines for that care planning process, and so we'd be remiss to not include them into stewardship. So again, for those of you, many of you who are infection preventionists, I think we serve oftentimes as natural partners for this work, and mainly because as a 50-year-old profession, we have an opportunity for a lot of to enhance our relationship building, which you do on a daily basis, and then also that organizational strategy, since you're involved in a lot of different broad committees or different groups across the board. So when I became interested in this topic 9 years ago, we conducted a review of the literature at the time. And again, our focus was really acute care. And we wanted to know how others were approaching antimicrobial stewardship and nursing. And at that time, I found about 13 articles. And that was really looking back past about 10 years worth of time. So really when those IDSA guidelines started. And the main themes we found within the 13 articles across the globe was really that, education is oftentimes lacking for nurses, and that also the other aspect is that organizational culture influences their desire or their ability to participate in these efforts too. Since that time, Australia's been doing a lot of work, actually has started prior to 2015. Australia's put several papers out around nurse engagement and stewardship, and actually Fiona Goddardson actually published an article in 2020 that really looked across all the different spectrums of care. So if you're really interested in diving into this more, there's a nice paper to that effect. But 3 years after I published my paper, the Olins team really started to look at the literature across the board, and I think this is just such an interesting review. And what they looked at is the total number of non-nursing journals and nursing journals, just to see around the scope of nurse engagement and the frequency of the publications of these. And really, what you see in the blue line is that non-nursing journals have really since 2015, have started to really see a larger focus, more submissions and interest in this particular topic, whereas the nursing journals have remained relatively static. So, and I find that a very curious piece too. So in other words, in epidemiology circles, we're talking to each other about this, but in the nursing community, not as much. And it's interesting, this actually comes from the American Journal of Nursing in 1961, actually. And so nursing and antibiotic stewardship or safety really isn't a new phenomenon. In fact, they warn against the promiscuous use of antibiotic use, talking about resistance, and the drug itself can be dangerously toxic to the sensitive patient. And I think that's a really important piece to focus on. And Dr. Vaughn mentioned this earlier in her presentation too. So when you're initiating a conversation, I tend to focus very much on antibiotic harm or antibiotic safety. And that happened because I was in conversations with my medical director at the time. We were talking to a nursing ethics committee around, who really owns antibiotic safety? Whose role is it to protect antibiotics? Is it really just one discipline's role or two disciplines' role that has that level of responsibility? And so asking them to consider that from an ethical framework. And I observed their faces when Dr. Goldman at that time said, resistance is a concern. We always worry about that and having the best treatments for our patients, but it's really more about ensuring patients are not harmed by antibiotics. And I saw, everyone's eyes got big, mine included. I thought, she figured this out. This is exactly what we need to be saying to different groups that we're talking to. So when I'm talking to direct care nurses around antibiotic stewardship or trying to figure out efforts of how to recommit to these efforts after the pandemic, I really couch those conversations on safety, because resistance really just isn't high, as you can see from Broom and colleagues, on their worry radar for that, when a patient is presenting to the acute care setting or to the long-term care setting, the immediate concern is about the patient. Resistance is really a downstream concern. And so from that point on, I've really started to initiate conversations around antibiotic safety and avoidable harm. So we know through our daily work language is important, and Dr. Vaughn's presented on this in other presentations too. And I wager that, for you that have facilities that may use huddle boards or maybe lean methodologies or other ways to kind of communicate or escalate concerns, financial stewardship is oftentimes the term that I hear people talk about when I'm like, oh, my ears always perk when people talk about stewardship. I'm like, oh, they're talking about the financial part. Never mind. But I find that when we're talking about antibiotic stewardship, sometimes the conversations I receive from nurses, they're like, well, that's really a prescriber to prescriber issue, right? It's really their work process. And studies indicate that, nurses when they're not exposed to those practice concepts in their nursing curriculums, we know that's fairly consistent. I think there's some movement and change as nurses are coming out and entering into practice, but a lot of this knowledge is really developing based on their own desire to learn more, or really it's incumbent, or potentially what the facility's interests are. And so again, while there are some programs that are really targeted towards nursing education, it's still relatively sparse. So when you're thinking about different areas and where you practice, regardless of what that is, consider reframing stewardship more as antibiotic safety, medication safety, again, because those are essential work functions that every nurse considers. I've also found in conversations too that nurses and other clinicians are often quite impressed by information that I think is fairly intuitive to this audience, but most are unfamiliar with the black box warnings on antibiotic use, for example, the permanent nerve damage or aneurysm risk. My hospital right in the center was one of the first ones that issued the first alerts related to Bactrim use and severe acute respiratory failure among healthy adults. And they continue to explore this topic further in larger populations. And so now, just asking the question, just if antibiotics weren't needed in the first place, or, in my scenario, when I was thinking about that C. diff outbreak all those years ago, we bleached everything under the sun, ruined a lot of equipment, made a lot of people very miserable. Maybe those antibiotics in the first place weren't necessary. So I think there's a growing trend within the stewardship literature to supplement standard performance measures. So thinking about days of therapy with measures that more closely reflect patient safety. And I remember that being kind of a shift when I moved from clinical safety into more of a stewardship role. I was not reviewing drugs. I was really more helping with the regulatory components too. So the piece here that I think is so interesting is Dr. Tama and Dr. Same from Johns Hopkins both looked at pediatric and adult perspective pieces. And when they did the review and they found, nurses and even providing clinicians are oftentimes not aware that the risk of an antibiotic-associated adverse event is around 20% for hospitalized patients. When children are prescribed an additional day of antibiotics, increase their risk by about 7% for an adverse event. And then again, as I mentioned, coming from a safety background, again, when I talk to nurses, when I talk to administrators on days of therapy, they're like, yeah, that's interesting, but I think it's the harm data that oftentimes seems to get escalated. And as you may know, reporting of harm data related to antibiotics is often incumbent upon the individuals to report those events, and it's oftentimes imprecise. You're looking at event reporting system trying to cull those records to see if there's anything associated with antibiotic and some level of event or a test in that event. And so I think because we don't often have a great way to convey that information, many times clinicians are unaware of those concrete dangers. So, from my facility, and I'm sure for yours too, is we like to share stories around stewardship and help to make that concept sticky. So in this example, the stewardship program reviewed a chart of an infant who was receiving IV antibiotics for a urinary tract infection and bacteremia. The primary team was planning to place a PIC line and treat with IV antibiotics for 14 days. The ASP provided the team with updated literature and that we could go to oral antibiotics. And because of this, the child was able to avoid a PIC line and all the associated complications that can occur from that, and a prolonged hospital stay during the pandemic. So again, as Libby talked about earlier, trying to help connect some of the stewardship work that we do on a daily basis to other initiatives that you may have within the hospital. And so oftentimes stewardship's connected to CLABSI work or other things like that. So again, that may help make that connection of that valid role, the valid role that nurses can play within this. So 2015, the Olin's team published this watershed article. It gained a lot of traction within the epidemiology community. And what they identified is, again, that nurses are already doing many activities on a daily basis that support the stewardship process, and starting anywhere from, looking at penicillin allergy, all the way through adverse events like we talked about, through the prevention piece like device management and preventing C. diff. And it's certainly not an all-inclusive list, but it is a good list to begin with. And I'll provide some examples in the upcoming slides, but I think role clarification, as they touch on, is certainly one that's still needed. And so, as you know, from leading any team activity, any improvement work, we always have an opportunity to clarify roles. And so from one of the studies that I was working on with members from Children's Mercy and the University of Missouri, we invited 9 different facilities to participate. Nurses graciously provided some free text comments, and what you're seeing today are a few of those. And what this nurse with a fair amount of experience shared is that it is not his or her place to question a physician's antibiotic orders. And again, I don't have the education in this area. I find it unfair for nurses to do this. Educating patients and other tasks related to administration is really within our scope. And in fact, just in case, pharmacists do a good job already doing this. So, thanks. And I find it very curious that, this is a very binary type of activity. So if you think about like heparin or all the other drugs that are risky that nurses administer on a daily basis, should I be waiting for a pharmacist to check that if, the heparin dose is too high? So again, as we studied these hospitals, one of the things that we found is that nurses recognize that many of the processes that they do help support stewardship activities, which is great. They were very, very confident and to perform many of those as well. And they wanted to be involved despite their reported limited education. But we also identified several things that bear further issue and attention, and thinking about that more from a systems perspective, which is nurses view antibiotic work processes as distinct. And I find that very curious. It's a deference to specialists working in this area. So antibiotics are inherently treated differently than, say, other drugs, high-risk drugs that they're giving on a daily basis. And that division of labor has been noted in other types of publications as well. And there was a separate pharmacist study, and they said that the role of the pharmacist's primary concern is to screen for drug interactions and to provide medication information rather than influencing the antibiotic prescribing process. So again, when I think of medication, the medication process in general, it's really all the way from prescribing to administration and evaluation of the effect. It's not a singular type of activity. The other thing too we found is that nurses reported trusting systems like the medical record, or that because unit-based pharmacists had already checked that drug, that again there was no need for them to provide that clinical expertise there. And then of course communication always is an area for enhancement too. So when we think about these stewardship teams, this is work that comes from Dr. Vaughn. And what she did is she looked at 500 hospitals, and the data showed that there were a number of different well-represented disciplines, certainly infection prevention. As you can see here, around 90% of hospitals, regardless of facility size, were participating in some level of stewardship activity. And then when you can see that nurses are really not participating, so about less than 50% of the time nurses have been engaged in this type of work too. So even though we have things like the CDC core elements or different accrediting agencies that are really calling for this diverse pool of individuals to contribute to antibiotic safety efforts, there's obviously an opportunity for us to increase that attention and continued conversation. So Dr. Katrina Merrill had also looked at this as well. So she submitted a survey to different nurses and tried to gain their perspective on knowledge and different attitudes. And they found, 80% of the nurses, not surprising to people, know why the drug is being prescribed. So indication isn't an issue. But they said, nurses were very reticent, including bachelor's prepared nurses, about questioning the dose, the duration, the route, and so all the other components that still involve the medication safety process. And in fact, 30% of nurses had given an inappropriate dose. So again, I think it speaks to the larger safety issue that's in place too. There was actually a Society of Infectious Disease podcast that came out, I think a couple years ago now. And it was talking about the pharmacist burnout. And Dr. Simzak was being interviewed for that recording. And the takeaway that I had from that is that clinicians may not be as confident to intervene when they don't prescribe something or perceive something as a wholly safety issue. So in other words, if you're kind of on the fence about it, they may not always intervene, whereas they will clearly intervene if it's very clear a safety issue. And so again, that may make some of the recommendations much harder to activate if they're not seeing that connection. So again, it's easier to intervene if it's very much rooted in safety. So again, just a consideration for you. So unsurprising, time constraints are a burden for many nurses. So again, this was a different survey that looked again at knowledge and attitudes around stewardship practice. Physician pushback was another component. Around 70% of nurses reported that. And, in the study that we did, this is something that was I think very helpful, is about half the time nurse leaders and physicians supported frontline staff. So we asked them on their perceptions as well. And so I learned this the hard way doing a couple different improvement projects where I engaged the frontline nurses. I had them all excited about doing this work. I had the CNO. She's like, yes, this is great, Elizabeth, keep going. And I failed to engage the operational leaders because they're like, why are our nurses doing this work? I need them to be doing some of the other things. So I thought this is a really important piece to remember, that there are different levels within nursing that you may have to message this to, and why that frontline nurse engagement is important. The scope piece on this I found to be very interesting too, as a majority of nurses reported that as a potential barrier. Again, I find it very curious that antibiotics are still treated very differently, even though safety is a fundamental aspect of those nursing roles. So as we move to the second objective about the practical examples, I also want to touch a little bit on wellness, because I know we're seeing that in the infection prevention literature, within the stewardship literature too. And I think we oftentimes conflate wellness with other types of social activities, the pizza parties and other things that may feel like self-care. And the Institute for Healthcare Improvement published this paper called Joy in the Workplace. And the main concepts behind that is that our job is really to create joy in the workplace, to reduce burnout, is really to elevate meaningful work in tandem with the non-meaningful work. So in other words, trying to create that sense of community, helping teams remove the pebbles in the shoes. And that's really what we've been trying to focus on within our stewardship program. What are the pebbles that people are feeling on a daily basis? What are the nurses reporting as issues? And then going from there to kind of help administrate solutions to resolve them. So Mary Lou Manning, again, has been a tremendous sponsor and mentor, and partnered with a couple of different professional societies. So we have FAPIC, we have FSHEA, we have the Society of Infectious Disease Pharmacists to put out the paper in 2018. And has really identified IPs have a unique role in doing this, mainly because they have substantial contact with the bedside nurses. They're involved in hack work. They sometimes do diagnostic stewardship efforts with the specimen collection. And then they know who the influential leaders are at the unit level. And so there's a very special place that infection preventionists can help provide support to this type of activity. So these are two nice papers that came out, and I think it speaks to my heart as far as, how do we engage different types of champions? And so the medical literature says, fundamentally, physicians who are in the medical side versus the surgical side, they communicate differently. And that's probably not surprising to many of you. And I think, it's refreshing because I've learned this the hard way of doing other improvement work, things that I thought would work beautifully in the ICU or an epic fail in oncology where they had multiple patients, multiple different other demands versus like a singular patient. And I think, sometimes we put a little emphasis on the wrong syllable for too much standardization in our work environment. And I think these papers really kind of call out that piece too. And so again, it's important for us to be able to foster those meaningful unit connections, because as this nurse reported, who had a fair amount of experience, has a big role in nursing tasks. They obtain cultures, good Foley and device care here, but in our unit, the nursing does not have any input on antibiotics prescribed, effectiveness, evaluation, start and stop times, or anything else. In my unit, prescribing information is left to the providers. And so from this location, what happens is this lab called pharmacy called the prescriber. They had a conversation around that drug modification, and then it was in the chart. And then the nurse really had no sense of engagement in that conversation. And so I think it becomes very important to think about what ASP interventions and work that may be conducive or maybe less conducive in a particular work environment based off of the systems that are already in place. And so again, when I think about this, an antibiotic timeout may be less effective here. There's probably some other method that might help increase that engagement because nurses, it would be redundant to the work that's already happening. So this comes from a NICU, and it's an interesting improvement example. And what they were really interested in doing is they wanted to reduce total antibiotic use. And so what they did is they had 3 main drivers, and you can see those listed here, that they wanted to engage charge nurses, they wanted to challenge a culture of culture-negative sepsis, and they wanted to reduce central line-associated CLABSIs. And so they did several PDSA cycles over time. They still kept those nurses engaged, and they saw a modest reduction in the antibiotic utilization rate. So now they said, we're going to pivot, we're going to focus a little bit more on CLABSI efforts at this point, and as a result, their mean antibiotic use declined and was sustained beyond the goal period. So again, I think that iterative approach really seemed to approach, it was really nice here, and it aligns very nicely with other initiatives that were already happening within the unit. This is a great work from David Hoff. He's now at Stanford, and Mary Betty Ford. Mary Betty Ford is a nurse educator. And what they did is that they thought, we're going to pair infection prevention activities and we're going to pair stewardship activities. And so twice a week, David, Mary Betty, and other folks went around on the step-down unit, and they helped have conversations with nurses. So when the prescribing teams would come around, the nurses would be more confident and better prepared to engage in those conversations. And it worked. As a result, they saw measurable reductions in antibiotic use, and they also decreased urinary catheter utilization as well. So again, pairing some of those nice activities together. So there've been a lot of traditional models when we talk about prospective audit and feedback, and when you think about the ambulatory environment, this comes from your colleagues from Nebraska. And, again, prospective audit and feedback would be very resource intensive in an outpatient environment. And we have an outpatient stewardship program. It relies on many of the tenets that Dr. Marcelin has outlined here. And from that model is what she's suggesting is that we really use C. diff in a positive way here, that we're using collaboration and communication by local leaders, that there's data, interventions, feedback, and follow-up. And it's oftentimes a supporting role to stewardship initiatives. So those frontline leaders, those urgent care providers, primary care providers, whomever your audience might be, are really the ones leading and driving it, and the role is more supportive in that. And so some examples when I think about the nursing role, which they call out in here too, is thinking about penicillin documentation or appropriate testing, and I'll give a few examples of that as well. So again, when I think of the different strategies for nurse engagement, I think we have a responsibility to develop systems that build confidence in nursing. And so they're really concerned about making the wrong recommendation. As this nurse reported, if we feel confident to suggest antibiotic changes, we'll do so. But the only thing I can think of that would make us not want to participate is we're going to assess the wrong thing or suggest the wrong thing. And then communication needs help. And again, I found that anecdotally in my own rounds or talking with nurses. We've done a lot of graduate nurse work in the PICU, and then we've done this on our cardiology floors too. And it is very, very different depending on the units of where they're at. But I asked these PICU nurses, I'm like, what would you do if you had a question about vasopressors? They're like, oh, well, I would do this, this, and this. And I said, what would you do if you had a question about antibiotics? And they're like, I would wait for the pharmacist to make rounds. And I thought, this is very curious that it's a different set of actions based on the drug. And so one of my colleagues, Dr. Carter from UConn now, she's looking at different types of tools because nurses have reported that tools would be very helpful. So you actually have something when you're actually communicating with the providers to say, this is why I'm asking this question. And that may be one mechanism to help build the confidence. So Ray Baradan and colleagues had a really nice improvement project. And what they did is that they engaged critical care nurses, and they wanted those nurses to prompt antibiotic reviews. And they said, it was modestly effective. They went through different PDSA cycles, but what really happened and what made the change after introducing a standardized script was priming the providers. So in that exchange, if I'm the nurse and I'm talking to someone, they would say, yes, Elizabeth, the reason I'm using this drug is for this reason, and here's why and what we can expect. And once that conversation really started to become bidirectional, they actually ended up having a result of reduction in days of therapy, which is a hefty measure to move. So in our own work within Children's Mercy and a couple of adult sites, we developed an antibiotic assessment. And this was born out of nursing interest, because they're like, if you want us to talk about antibiotics at care transitions, which as you all know are a challenging time for many patients, for the clinical teams too, because they just aren't always sure about the therapeutic plan. So when I approached them, they're like, well, I'm not sure really what you want me to ask at this particular time. So what we did is we worked with them to design this tool, and it's called AUDIOS, but it stands for whether the antibiotic is present, what the duration is, what the indication is the patient taking anything by mouth? So then it would help inform that maybe sometimes providers, as they're making rounds, aren't aware that the child is taking things by mouth, and we have different strategies to help do that. Or in the adult setting, that pharmacy can also help make sure that they can start to take oral therapies, and any suggestions that they may have too, because our medical providers were reporting, sometimes you come in the next day and you find out that the the peripheral line has been changed because it was sluggish, and the nurse was having trouble all night with it, and so they put a new peripheral IV in, and in fact I probably could have switched them over to a different drug at that point. And so again, things that nurses may observe on a daily basis may not always get escalated to the teams that are prescribing, and so the tool was intended to do that. And so the nurses, what they shared with us is that it did help them ask those questions around antibiotic therapy. It improved access to information, increased some confidence in those discussions. We did not look at measures like did it make any more changes, because that's a really dicey thing to try and find in the charts. But we also learned too is that nurses are very patterned as far as if I'm on this unit, I'm expecting these antibiotics to be given for most of the conditions that I'm seeing when a patient presents. But in the presence of polypharmacy, that became much more confusing too. So maybe just an area for you to think about if you've got people on a lot of different drugs, that may be a point of conversation. So, nurses have reported to me too, they're like, Elizabeth, I'm happy to have these conversations, and I kind of use this technique and what I call is kind of the hint and hope. They're like, I kind of ask in a roundabout way, have they considered some of these different things? And so then the physician won't see it as a challenge or that I'm policing them, because obviously I don't have that education, and it just never seems to go well. And so like Tarani and others have reported versus that medical versus surgical type of communication, again, nurses communicate differently than physicians do. I mean, it was 100 years ago, but when I was taught, how to do a history, it was being taught as a story. Learn the patient's story, that's what you're communicating as part of the report. And so it tends to be more narrative. So again, methods to reduce that hint and hope can be potentially using things like SBAR, so situation, background, assessment, and recommendation. We use it in high reliability industries to help relay that clinical information. And so again, just an example of like if a nurse saw that there was an order for C. diff, the patient's on a laxative, maybe that test needed to be ordered at a different time. So this is a nursing home example from Bayer and colleagues. It's 21 facilities, and what they did is that they focused on the antibiotic review versus antibiotic starts, and they based that information from prescribers that they said it would be very difficult to change that initial prescription. And so they had 5 pilot sites in a 2-month period, and so there were 8 in the intervention, 8 in the control. And what they did is that they created this bundle of tools. It was in the medical record now. It's standardized documentation. They replaced the paper-based one. And the nursing actually said it was very valuable to them, but their uptake was a bit low. So I think it underscores, again, those iterative rounds that still need to happen as you do improvement work too. Bottom line, the intervention group actually performed better, and they stopped antibiotics sooner. But again, nurses were engaged in this effort, and Dr. Jump has done quite a bit of work around nurse engagement in the nursing home setting. So as we round out our time together and we think about that third learning objective, I'd like to really focus on that synergistic relationship between infection prevention and stewardship, and I'll touch just for a few moments on diagnostics as well. So I think the final strategy, so I've identified 6 different strategies, but that final strategy is really, again, how do we create space for these really important conversations to have with nurses and the shared learning that can happen. And I think there's a lot of great perspectives that either facilitate or hinder that depending on what's happening. So this is a fairly new nurse, and the individual has reported that, providers should be asking staff that work at night to have input on the antibiotic treatment and therapy. In addition, night nurses are not provided the tools to have proper IV access, such as midlines, to keep patients free from phlebitis. When high-strength antibiotics are ordered, that delays treatment, and sometimes the loading dose, the maintenance dose, is oftentimes received late. And so again, these nurses are recognizing things that might be like opportunities within the stewardship team to engage them in those efforts. And I think this segues very nicely to work that Manning has done around creating a framework around antibiotic stewardship nursing practice. And it really begins with the idea, again, many of these folks were IPs that helped develop that, but starting with the scopes and standards of nursing practice, and then moving into culture concepts and competency. And the idea behind that is we know that organizational context, work ecology does influence participation in these efforts. And then thinking about selected practices. And the two that you can see, vaccine promotion is one of them, education is certainly one of them, making sure the administration process is safe to keep patients from harm. And then, of course, antibiotic allergy and microbiology testing practices. She's also published, if you're interested, there's also some nursing education that's come through her, and I've seen some other people also share some of this as well. So again, that aligns with another publication that just came out a couple years ago from Kara Johnson and Amanda Hessels. And what they did is that they looked at studies over the past 10 years. So as I said, we're starting to see more papers come out in the epidemiology journals. People are have more interest in this. And they found close to 200 articles, about 10 of them detailed nurse engagement. And the bottom line is they're like, if you have to pick some areas to focus on, we certainly need more research, more improvement work related to culture and testing practices and penicillin allergy evaluation. And I think that aligns very nicely with what we see within the core elements, where, again, nurses can enhance those evaluations, can support stewardship processes, particularly through the optimization of microbiology cultures, which in turn, as you know, leads to downstream appropriate antibiotic use. And I also think it's a more intuitive angle when I talk to nurses when I think about diagnostics, because oftentimes when I've presented to them, I'm like, we could be engaged here, here, and here, and they're like, yeah, but, one of the things I really want to know is why do they keep ordering the same test, or, day after day, or the repeated ones, or other questions related to that. And so one of the projects we started to focus on is looking at penicillin allergies. This is part of an improvement project. It was in our urgent care. Again, I was talking to nurses around just in general about stewardship and how we might think about different activities. And I'm like, part of it is when patients present, the parents or the guardians or whomever is bringing the child in doesn't always, they'll report a side effect versus a true allergy. And then I feel like I need to document it. I'm not sure what else to do with it. And so this project was really born from those conversations. And so what we did is we had multiple nurses from 3 different urgent care sites. We had prescribers engaged in it. We had pharmacists, APRNs. And this team really hung with us. This was it was still in the middle of COVID and through the past several months where we just finished the project. And what they wanted to do is actually look at allergy labels, because they're like, we notice a lot of times it's unknown or blank, and then the urgent care provider's like, I don't know, the whole history, and so it's leading to a different antibiotic being selected. So what these folks did is that they started to try to understand that further by capturing some of these data to look at different self-paced modules, and then also to create an algorithm that helps nurses go through the scripting process to have the conversation with the providers as well as the family. And one of the things, too, is I think when we think about microbiology specimens, I think that's a key place where IPs can help duck into the work, too, mainly because, it's going back to the environmental scan. We already know IPs help with data analysis and a lot of different other stewardship activities, but about 20% of the time we found nurses spending about 5 hours or less doing this type of work. And so that may be a place that helps influence the data that you're collecting, as well as a way to engage them in stewardship. So we know algorithms have been helpful. There's a lot of great examples in long-term care. Valeria Fabre out of Hopkins has done some work with nurses to look at a nurse-driven urine culture diagnostic stewardship effort. And then even on the pediatric side, thinking about testing in an outpatient environment, making sure that we're not broadly testing everybody for group A strep, so clinical practice guidelines to also minimize, again, broad testing of children instead of treating, actually treating infection versus colonization. So just a few more examples before I close, but this has generated a lot of conversation, at least in the pediatric community. I would presume, I just saw another paper come out in ITCHE related to adults and blood culture stewardship. And so what they did is that they formed a collaborative. They engaged, again, a variety of different disciplines. They started a clinical practice guideline, and then they also have this checklist that's for fever and sepsis. And what they wanted to do is they wanted to make sure they didn't miss anybody. Everybody was concerned around missing sepsis in the ICU, which was understandable. But what they did is that they wanted both the nurse and the prescriber to actually have a conversation about, whether a blood culture may be warranted or may not be warranted. And then after it was completed, they kind of signed this off and submitted it. And in my experience, this is oftentimes where nurses were asking the question, how many lumens do you need? This was done yesterday. Do we still need another blood culture? Why are we getting this blood culture? And I think it was alluded in an earlier presentation, would this have any bearing on other types of tests, tracheal aspirates, urines, and other things too, if you actually limit some of the blood cultures? And what they found across multiple different sites is that it reduced CLABSIs, it actually reduced broad-spectrum antibiotic use, and then the initiation of new antibiotics too. So it was a very impactful improvement project that they're starting to roll out to other types of initiatives, including tracheal aspirates and urines. So this is actually a poster that we're presenting today at a pediatric stewardship conference. So I have a nurse from the PICU who's sharing some of this work, and it was really born out of nurses several years ago, in fact 2017, where nurses in the PICU were saying, we see a lot of variation. Some prescribers order blood cultures, or this many from these many sites, and all of these different questions is confusing. And so they've done some chart reviews to look at that and reported back on some of the data, but we took that work system assessment that Hopkins had done, modified it, really looked specifically at nurses, and found, that they agreed that lots of blood cultures were being ordered, that oftentimes practice variation was a barrier to optimal performance. And they said, oftentimes too, getting those peripheral sticks were difficult because, again, you have a maximum blood volume or other issues that we may not always be considering. And so again, there's, some work that's happening within our PICU, and this was largely driven, I should say, from frontline nurses that recognized that there was an opportunity to examine this further. And so my final slide on, again, a nursing issue that was brought up is we were actually around and, again, talking I was with our co-director of stewardship. She's a pharmacist and just a wonderful, thoughtful leader. And we were rounding, and this nurse said, Elizabeth, this is really interesting and all, but she's like, we're wasting all this cefazolin. And this was a post-operative unit, and, it comes up, our process was it'd come up several bags at a time. And so think about the little pharmacy tech down there that's, making sure all these bags get up there in a timely manner, and then we're wasting this drug. And our pharmacist was understandably quite pale because it's oftentimes on shortage, and started to dig into this a little bit further and found that, again, many of the order sets had this extended use time. And so it prompted her to delve into this work further and found that we were wasting about $250,000 a year related to this, about 50 doses of antibiotics a day. So again, thinking all the way from someone's time and preparation to do that, which doesn't feel good. And then all the way through, again, where does it get dispensed? It's just, there are a lot of different pieces there that, again, it was brought up because of some nurses that said, this doesn't seem like a good practice for us. So in closing, again, I'd like you to leave that nurses can and should make significant contributions. I think nurses are absolutely critical to advancing stewardship across that care continuum. I think developing a shared language around safety can help strengthen a collective mindset around stewardship work. And then, if you're thinking about different activities, some that may, again, be relevant in any practice setting would be that penicillin allergy, culture and testing. Those are some options. And then there's a nice book around the geography of genius. And, we always think of genius as being something that someone's just brilliant. It's just wholly innate. Nothing else has to do with it. And in fact, when he started to look at different creative places and cultures that have these individuals who've thrived, and what they found is that they create space for that ideation, for that creativity. And so again, I think, our charge, be that in infection prevention, within stewardship, whichever environment that you're in, is really thinking about learning as a social act. And I think it's through us sharing our wisdom with each other that allows us to develop. And so with that, I thank you very much for the opportunity to be here with you today, and I'm happy to take any questions if there's time.
You didn't
Kate?
disappoint. That was awesome.
Thank you.
My question, it really involves your last bullet point there.
Yeah.
I was intrigued by what you were describing as kind of these qualitative rounding experiences.
Yep.
I'm really interested to know how do you plan those rounding opportunities, and what do those conversations look like to make sure that those conversations are heedful?
Yeah. So I'd love to say that we were super structured, Kate. we were not. It really started with just, again, impromptu, going around, getting a pulse from the unit if people are available and saying, hey, we're thinking about this. What are your thoughts just off the top of your head? We have been very deliberate to make sure that we've gone to different nursing committees and to try and keep it just still at the forefront. So I still talk about that. And I also, as like Libby said, figure out different ways that you can enhance your messaging. So for example, we're a magnet designated facility. Part of magnet is nursing-led activities need to happen. And I have Kathy Bahrain from the PICU sharing this poster at another conference. And so nursing has supported that effort. They can create visibility. So it's really, it's not my work, it's their work, right? It's creating an environment that allows them to study an issue that's important to them. So.
That's awesome. Follow-up question, since nobody else is coming up to the microphone. I invite any infection preventionists specifically to come up, maybe. The final question, specifically, it's very simplistic, but would you script for us? What are some of the ways you ask those questions when you're rounding? What
Sure.
are some of the things you say?
Yeah. So usually, again, I'm happy to do something more offline with you if that would be at all helpful. But oftentimes, I do talk about the work that nurses have done before. So I tend to share what their colleagues have done. So specifically pointing out nurses that they know. Again, those influential leaders like Manning and others, Libby was on that paper too, that point out that they already know those folks. So I said, Kathy just presented this. What are you seeing? Because this was something that was important to her. Is there something that we can help you study? And in fact, it actually came organically the other day. I got an email from some nurses a few weeks ago, actually, where they wanted to look at UAs because they said, we're getting all these UAs before surgeries. Nobody else is doing it, just our service. And so stewardship started to look into it. The nurses are really interested. They're like, we'll keep an abnormality tracker. It's creating a place and space for that. So, yeah. Thanks. All right. Well, thank you all.